individual form of posterior uveitis and tell you how to manage it. What I'm trying to really give you is a practical framework of what to do. And so to start with, I've got some relevant financial disclosures. To start with, I'd like to actually go back to that 7-year-old boy with the sympathetic ophthalmia, because I think he just demonstrates really the sort of the thought process that we had to go through when he first presented. Okay, so essentially you remember when he presented, his left eye was at risk. Okay, he already had no sight in his right eye, and pull our left stop to try and get his left eye under control. So what we did is we admitted him and we pulsed him with IV methylpred. Okay, we know it's a non-infectious cause on the history and examination, which is classic sympathetic. We had to pulse him. Now, there are two things here. We need to get his inflammation under control, and then we have to think about the future, okay? Now, we know sympathetic is pretty much a lifelong condition, okay? It's ongoing. It's not going to be over in 3 months' time. So not only did we pulse him, no, I don't think this is right. Not only did we pulse him, but we also had to think about how to keep his inflammation under control in the long term without ongoing systemic corticosteroids. Okay, so we also concurrently started him on steroid-sparing agents. All right, now firstly we started off with methotrexate. The reason for it is because he's a child, okay, and this is 15 years ago, okay, where we didn't have easy access to a lot of medication. Started him on methotrexate, and then had to also add on cyclosporin. Okay, as a dual steroid-sparing prong, okay? And despite starting both the methotrexate and the cyclosporin, we actually had difficulty reducing his oral prednisolone down to less than 20 milligrams a day, okay? In a child, that's not an acceptable long-term dose of corticosteroid. As most of you know, it's going to cause side effects, okay, and it also stunts his growth. So essentially at that point in time, this is now 2 months down, okay, 2.5, 3 months down that we were actually struggling. We actually were trying to actually give the methotrexate cyclosporin a chance to actually kick in, so he actually also had a lot of periocular and intraocular steroids into his left eye, which was his only eye, to try and keep that inflammation under control, hoping that it would be enough to actually then keep him under control long term without high-dose oral prednisolone. We were still struggling at that stage, and that's when we started him on infliximab, which was the only TNF inhibitor that we had available at that time. And fortunately, we were then able to control his disease. So that was then, that's his uveitis, his sympathetic came under control. We were able to get him off the oral prednisolone, didn't require any further injections into his left eye. We also enucleated the right eye, which was blind and painful at the time. It is controversial about enucleation in sympathetic, and it's a bit beyond the scope of this talk right now, but we did enucleate the eye as well, and everything all combined, we were able to save his eye. He's now 10 years post, because I first met him 15 years ago. He's now a lot taller than me, which is a good thing. And he's currently quiescent. And obviously now, he's 10 years on infliximab, and we were able to stop all the other treatments. So able to stop the methotrexate, cyclosporin, oral prednisolone, no further injections. So this is exactly what we want to do. Okay. With all of our patients with non-infectious uveitis, we all want to try and quieten down that immune system, okay, and keep him sighted. All right, we don't have any treatment. We have no treatment that will switch off the inflammation like that, so it never comes back again. All right, for a lot of these chronic diseases, I tell my patients, the whole idea is to dampen the immune system down so that eventually when the immune system resets itself and stops fighting your eye, you will still be able to see. So all of this is to really save your patient's sight. Okay. So the general principles. Now the general principles of posterior uveitis management is very much the same as the general principles for uveitis management in general, okay? And the challenges, you've already seen the slide. With repression, I've already talked about what am I dealing with, okay? I'm now going to start with treatment. When do you start treatment and what should you use? Okay, so 3 things. Assess the course of the disease, decide whether or not you actually need to treat it, and then assess the cause of the vision loss, okay? Number 1. Okay, number 1. What is the cause? Now, repression, I keep telling you this, okay? Always exclude the possibility of infection. Cannot emphasize that enough because that is where we always get the mistakes, okay? And consider masquerade and atypical cases. Repression's going to talk to you about that shortly, Okay. All right. Is there a reason to start treatment? Okay. Indications for treatment are patient symptoms that are severe enough to warrant treatment, okay, and sight-threatening complications, either right now or in the future. Okay. These are the reasons why you would start. What are the cases where you wouldn't start? Okay. Mild intermediate uveitis or mild pars planitis at presentation, okay, is something where they've just got some floaters and that's pretty much it, maybe a few snowballs, but no cystoid, no anterior segment inflammation. You could watch those patients for a little while. Okay. The reason I say that is because there are some forms of intermediate uveitis and pars planitis that just grumble, okay, and they grumble and grumble and grumble and they never get sight-threatening complications. This is a difficult call. Okay, but sometimes what you need to do is just get some sort of handle on the rate of progression of that patient's disease. Another form where you might not treat is, as Rupesh has mentioned, is peripheral toxoplasmosis without severe vitritis. Okay, not immediately sight-threatening, and we know it is a self-limiting episode, it will settle down. Okay, so these are the things you've got to think to yourself. Okay, has the patient got severe pain, can't see, any of those things, that's when you treat. Or patients with grumbling, anterior uveitis, JIA is your classic, where you know that if you don't control the inflammation, they're going to end up with sight-threatening complications like glaucoma, band keratopathy, cataract, which is going to be really difficult to control. So these are the reasons why you would start treatment. Okay, firstly, what is the cause? Hang on, wrong way. Okay, causes of visual loss. Now again, you need to split this into inflammatory causes and non-inflammatory causes. Inflammatory causes means you need to treat that inflammation now. Alright? That's the number one priority, is get rid of the inflammation, and then you can deal with the non-inflammatory causes. Alright, what are the causes of non-inflammatory vision loss? Okay, all of these. Cataract, vitreal debris. Okay, chronic macular changes, this is not cystoid, but this is atrophy or lamellar holes. Okay, and subretinal fibrosis, choroidal neovascular membrane. These are generally non-inflammatory causes that don't respond that well to just more steroid. Okay? What you do need to do is get rid of the inflammation, deal with the inflammatory causes of their visual loss, and then come back and deal with these once you've got the inflammation under control. Alright, if you try and deal with these when you've got active inflammation, you're going to get yourself into a whole lot of trouble. Alright? For instance, cataract, okay? You can see it there. Okay, but if you actually go into a hot eye, so an eye that actually has inflammation at the time that you do cataract surgery, they're going to do a whole lot worse. You need to keep them under control for at least 3 months. Okay, that's, it's very arbitrary, but I want to get them under control prior to doing anything like that, any sort of surgical treatment for the management of their non-inflammatory causes of visual loss. Okay, so then you need to think about how am I going to actually manage their inflammation. Am I going to go with local treatment or am I going to go with systemic treatment? And a lot of this depends on the disease and the patient sitting in front of you, and I'm going to go through those. So as I mentioned to you before, the treatment of uveitis is drops, shots or pills. Okay, because this talk is mainly talking about posterior uveitis, so I'm really going to be talking about shots and pills. Okay, so what are the treatment strategies? These are all the ones that are at your disposal. And in the acute situation, what we do is what I do is really look at steroid, okay? Corticosteroid in its various forms, okay? To suppress it or get rid of the inflammation first up, okay? And like my young boy, okay? In chronic patients, when you know that the disease is going to be long-term, then I also will start a steroid-sparing agent in anticipation. Only because all forms of corticosteroid, okay, are not a chronic treatment. And that's probably the main sort of principles that I'd like to talk about today. Okay, so what sort of approach? This is just general, speaking generally, okay? So unilateral disease, if it's a short duration disease, okay, and it's unilateral, I'll go with local therapy. Whether or not that's a periocular steroid or an intraocular steroid, after excluding infection. Okay? If I think it's going to be a chronic course, okay, I will combine the local treatment with a systemic steroid-sparing agent. Only because steroid-sparing agents take months to kick in. Alright? They are exactly that. They're steroid-sparing agents. They are to keep the inflammation under control so you can actually take your patients off the steroid. All right? If it's systemic steroid, it's to reduce the dose of the steroid. Okay? If it's local injections, it's to reduce the frequency of those injections. It's all about steroid-sparing management. Bilateral disease, in the acute course, I generally use oral prednisolone. However, bilateral injections is also a possible treatment regimen as well. Whether or not you're comfortable or your patient is comfortable to have bilateral injections is another thing. Okay, and again, if it's a chronic course, combination of systemic steroid-sparing agents. Okay, what to use and when? Okay, it depends on, again, the patient sitting in front of you. How severe is the disease? How long is the disease course likely to be? Okay, and do they have any other systemic comorbidities that's going to make your management or going to complicate or influence the type of drug that you're going to choose? Okay, and if you are going to go down systemic immunosuppression, I highly recommend you do this in conjunction with a physician. Alright, so I'm just going to go through some of these treatment options. Okay, periocular injections. I use triamcinolone. In the past, it was a combination of dexamethasone and methylprednisolone. I find that triamcinolone doesn't hurt as much. Okay, it doesn't sting as it goes in, and as a result, you can use it neat. No combination with a local anaesthetic required, and as a result of that, then the patients don't tend to get that diplopia. I use a 1-inch 25-gauge needle, and I actually go through the lid. There are lots of different ways of doing this, including a subtenon superiorly. I tend to go through the lid so I can actually put my finger there and I can see where the globe is. Okay, go along the inferior orbital margin, border between the medial 2/3 and the outer 1/3, and just track it along the orbital floor. Okay, put it in until you hit the hilt, or until that hub is at the iris plane. Okay, always draw back, make sure that you're not in a vessel, and then inject slowly. All right, now it's effective in around about 50 to 70%. In my book, it's about 50-60%, so it's not 100%. Okay, and duration is usually typically 4 to 6 weeks. There are some who say it lasts up to about 3 months. I think 3 months if you're lucky. Alright, so it's particularly good for short-lived unilateral disease. The classic is Irvine gas, cystoid macular edema, that hasn't responded to topical therapy. Okay, or lingering cystoid after you've dealt with the acute uveitis. So as many of you know, okay, once you've actually got the inflammation, the cells and the haze under control, sometimes even though the eye appears quiet, you have lingering cystoid. Okay, and this is where a periocular injection is quite handy. Alright, now side effects, okay, no steroid is clean, okay, and basically that includes local delivery, okay, glaucoma in up to 35%, cataract progression is 0.06, okay, IPU, so it is cumulative, okay, and also you can also get diplopia in about 1 in 200, usually transient, but sometimes very rarely permanent. And lid changes, if you actually go superiorly, you can get ptosis. If you go inferiorly, you can get orbital fat prolapse. And obviously, if your patient jumps, globe injury, and certainly there have been instances of, unfortunately, inadvertent intraocular injection of steroid in an orbital floor. That's one advantage, I suppose, if you want to think of it that way, of using triamcinolone, that unlike methylpred, triamcinolone is not toxic to the intraocular contents of the eyeball. Okay, intravitreal injection, again I use triamcinolone, 0.1 ml, which is 4 milligrams neat. Okay, 3.5 or 4 millimeters from the limbus, 3.5 in pseudophakics, 4 millimeters in phakic patients. Watch the central retinal artery closing pressure. Okay, unlike the anti-VEGFs, you're looking at double the volume, so you're more likely to close off the central retinal artery. So I do this with my indirect on and with my patient sitting upright. Okay, because if the patient's lying down, all right, you'll end up with a triamcinolone over the optic disc, and the patient's not going to be able to see anything, and you're not quite sure whether or not it's due to your triamcinolone bolus or due to the fact that the central retinal artery hasn't occluded because of the increase in volume inside the globe. Okay, so that's just one little hint for you. Again, very effective. It gets it right into the eye there, and the concentration of an intravitreal is about 6 times the concentration of a periocular steroid. So very effective. The downside though is you're more likely to get the side effects, okay? So up to 50% will get a rise in the intraocular pressure, and cataract will also develop at a much more rapid rate. Also, because you're going intravitreally, you're also looking at all the other complications that we see with all intravitreal injections. And I would also just say that I generally don't like to inject triamcinolone in patients with known advanced glaucoma, basically because particularly in the young patients they can get a really high pressure eyes. So when do I use it? I usually use it in patients with recalcitrant cystoid. That's really, really helpful. And in cases where the inflammation is likely to last a little bit more than a month. It's also good for patients with chronic disease where I'm about to start a steroid-sparing agent and there are systemic reasons why oral prednisolone would not be a good idea. Okay, we know that the triamcinolone intravitreally will last around about 3 to 6 months. In my book, it's usually 3 months. And that gives you time for the steroid-sparing agent to actually kick in and hopefully reduce the need for another injection. Okay, now one of the controversies with triamcinolone is this sterile endophthalmitis, or TAS. It usually occurs within 24 hours of your injection, and the patients complain of acute loss of vision, and what you see is a quiet sort of hypopia at the front of the eye. I'm not talking about a pseudo-hypopia, which is when the triamcinolone is actually migrated into the anterior chamber. I'm talking about an actual inflammatory response to the triamcinolone. Now, there has been some controversy about whether or not this is due to the preservative-containing steroid, like Kenalog or Kenacort, or due to the drug itself. Okay, and I'd just like to highlight that sterile endophthalmitis has occurred with both the preservative-free triamcinolone, known as triesins, as well as the preservative-containing triamcinolone. And so, essentially, just by using the preservative-free triamcinolone, you may not actually negate the risk of getting sterile endophthalmitis. The thing about sterile endophthalmitis is the patients generally don't always complain of a lot of pain. The eye doesn't seem quite as hot, and it does settle down without further treatment. But if in any doubt, tap and inject as you would with infectious endophthalmitis. If you're in any doubt, that's the safest option. What I generally do, if I think that my patient's got sterile endophthalmitis, I keep them in my rooms. Feed them coffee, or whatever. I just sort of say, look, there is a chance that this might be infectious. If it's infectious, you're going to get a whole lot worse, okay, over the course of 6 hours. Whereas with TAS, what happens is they stabilise and they actually start to get better. So it's just really frequent observation before doing a tap and inject. If in doubt, I keep them fasted for the whole duration. Okay, other intravitreal therapies are also on the horizon. These include anti-VEGF, so there have been a few papers using intravitreal bevacizumab for uveitic cystoid macular edema with some efficacy. I've generally found in my hands it's really not as effective as triamcinolone. You need multiple injections just to try and get some effect on the central macular thickness. The same applies with methotrexate. It's the same dose as what we use in intraocular lymphoma, but at a less frequent dosing regimen. Again, it's been reported to be effective in up to about 70%, but I've generally found it's definitely not as effective as triamcinolone. But certainly these two are options for patients who are known to be steroid responders or patients with significant glaucoma, and certainly both of those are also subject to a randomised controlled trial at the moment through the NIH. Sirolimus is something else that you might have heard of, currently under trial, both as a subcond injection or intravitreal. Again, it has been subject to studies and seems to be effective, but again, we're still waiting on the final results of that. One thing I would like to highlight is that you can get sterile endophthalmitis like with triamcinolone with sirolimus as well, and that seems to be a dose-dependent effect. Okay, so steroid implants, basically the two steroid implants that are currently available are the Retisert implant as well as Ozurdex. Basically with the Retisert implant, it's fluorocinylone in a pellet, and you can see that here. I don't think this is bright enough, but you can see that that's a pellet on a plastic strut, just like the Gain-Cyclovir implants, and that actually gets sifted into the pars plana there. Now, this lasts for up to 3 years. We're getting it probably closer to about 4 or 5 years in efficacy. Everybody gets cataract with this, okay, and that's all to do with the chronicity of the steroid that goes in. There's also very high rate of glaucoma. Around about 30 to 50% will get glaucoma, and a third of those will end up with a trabeculectomy, with surgery. Okay, hypotony and retinal detachments have also been described. Okay, The MUST trial is the trial that actually is a randomised controlled trial comparing patients with posterior intermediate hand uveitis, and they were randomised between getting bilateral reticerts if required or systemic immunosuppression. And this is now out to 5 years. These patients are randomised between those two treatment paradigms, and it basically found that both treatment groups did well. Okay, nice to know that standard therapy works, but they also found that reticert works very nicely. And interestingly, the implant group had better control of uveitis at 24 months, but particularly patients with CME did a whole lot better with the reticert than systemic immunosuppression. Now that all sounds great, but these are the 2-year data results. Okay, and as I mentioned to you before, very high rate of complications. Greatest intraocular pressure, 61% in the implant group versus 20% in the systemic immunosuppression group. They all got cataract. But, initial conclusions, as I said before, they both work. Significant ocular complications in the reticert group, even though it did have a better control of the cystoid macular edema at 2 years. And the quality of life scores, interestingly enough, were fairly similar, generally favouring the reticert group though. 5 years on though, what we found is that unfortunately the pellets on the struts are all falling off because it really seems to dehisce. Okay? The first one occurred at about 4.8 years, but now some of those patients are now up to 6-7 years, and we're finding a whole lot of them are falling off now. Okay? Now this is a problem if the patients are vitrectomized particularly or have a very cynoretic vitreous, because the pellet then sort of dings around everywhere. Okay? And so the patients will say they wake up and there's something right in the middle of their vision, they get up and it sort of swims around everywhere. It's particularly a problem in patients who are aphakic, because what happens is that the pellet can migrate into the anterior chamber, causing corneal decompensation, and requires immediate removal. And so essentially this is becoming a big problem, and I feel that the reason we're seeing it with these patients rather than the gang-cyclovir implants is because these patients actually are living longer. The gang-cyclovir implants were in all those patients with AIDS who eventually died of AIDS-complicated diseases, complications. The 5-year results have also found that the systemic immunosuppression group are actually getting better visual outcomes out to 5 years. The reason for this though, and this is confounded by the fact that patients with systemic immunosuppression remain on the systemic immunosuppression forever, not forever, but throughout those 5 years. Whereas the implant group, we don't immediately re-implant them at 3 years, we actually wait for a relapse and therefore reduced vision before we put the second implant in. And so basically it's hard to interpret these 5-year results in that sort of setting. Okay, moving on to Ozurdex. Okay, as some of you might be familiar with this is a dexamethasone in a solid bioerodible implant. Okay, it's injected through this injector again at 3.5 or 4 millimeters from the limbus in a stepped wound. Okay, it actually has a biphasic release, so maximum release over 2 months and then a slower release over the following 4 months if it lasts that long. Generally, it lasts up to 3 to 6 months. In my book, it's really closer to 3 to 4 months. Some patients make it out to 6. And the neat thing about this implant is that unlike Triamcinolone when you inject it in, it lasts just as long in a vitrectomized eye. Okay, so if you've got an eye that has been vitrectomized and you need to control the inflammation, like say cystoid or it's usually cystoid, Triamcinolone doesn't last long in a vitrectomized eye. I get around about 3 weeks, 4 weeks. Okay, whereas the Ozurdex will last out to 3 to 6 months, which is very, very handy. Well, I think this is dying. Okay, so Ozurdex has been subject to randomised controlled trials in uveitis, found to be effective with regards to reducing vitreal haze and improving vision. Unfortunately, this study was done about 10 years ago, so I can't really tell you central macular thicknesses and the effect on macular edema, largely because we didn't have OCT when this trial actually was designed and started. Okay, complications as expected, ocular hypertension in up to 40%. Okay, so I still find that if you've got a patient who is a steroid responder, they will still get a high pressure with this stuff, despite some claims that it actually has a reduced rate of glaucoma. And again, cataract is an issue as well. Okay, Illuvian is also also out there. It's a fluocinolone solid implant similar to Ozurdex, but it lasts 3 years. It's largely been trialled in diabetes with some CMV from A and D, but at the moment still on hold with regards to uveitis trials per se, although there have been some case reports. Okay, moving now on to systemic treatments. Okay, so we're talking about prednisolone, we're talking about steroid-sparing agents and biologics. Okay, so prednisolone, either given orally or IV methylpred, pulsed daily for 3 days. It is the strongest, most effective medication we have with the quickest onset of action. Okay, and the standing starting dose for oral prednisolone is 1 milligram per kilogram, which is then taken over weeks to months. Now, the thing to remember about oral prednisolone is that virtually everybody gets side effects of some shape or form. Okay, everyone gets side effects. And the small percentage who don't get side effects generally are not taking their medication, usually. Okay, so long-term steroid treatment is not an option because of the side effects, because all of your patients will end up looking like this. Okay, and you also will shorten their life. Now, it used to be that people were advocating that if you can get your patient down to 10 milligrams a day, that's a safe dose, okay? But actually, it's now, people are now saying, no, 10 is too high, then it was 7.5. Now they're saying that's too high, and now it's come down to 5 milligrams or even less for younger patients. So that's the issue here, is that long-term oral prednisolone generally is not an option for maintenance treatment. Okay. Which moves us to steroid-sparing agents, and this is for chronic disease now. They suppress the immune system, but they usually take much longer to act, okay, weeks to months, okay? They take a lot longer to act than corticosteroids, and that's why, you know, usually when I start a systemic corticosteroid-sparing agent, I start at the same time as the prednisolone, okay, or the intravitreal triamcinolone injection. Now, they're also used in chemotherapy, and a lot of my patients say, oh, but that's chemotherapy. And I said, yes, it's the same medication, but we use it at a tiny dose, not like chemo, which is much higher doses, and I can sort of alleviate their sort of concerns in that regard. And yes, all treatments have side effects. That includes steroid-sparing agents, but the incidence is far less. So it's not 99.9% that you have with systemic corticosteroid. It's around about closer to 10 to 25%. And if your patient doesn't tolerate one, you can usually find another. Okay. Now, these are all the steroid-sparing agents, and this is not a complete list. This is the ones that are readily available at the moment. And it's really, my aim here is not to be able to get you all into being internists and administering your own systemic immunosuppression, but what I can say is that there are some really nice papers, and you'll get the references for these, on just guidelines on systemic immunosuppression, both with the standard steroid-sparing agents like the antimetabolites and the T-cell inhibitors, but also the biologics. And these are two very nice references that just give you a little bit more understanding about how all of these drugs work. Okay. And now, the key thing here about systemic immunosuppression, as I said before, is that not to try and do it on your own, okay, unless you've done rheumatology or an immunology sort of advanced training, okay. This is something best done with an expert in the area. It's the same way as a rheumatologist doesn't treat uveitis, okay, we should not be treating meningitis disease on our own, okay. And so basically it's all about teamwork, okay, and it particularly applies to patients who have multiple comorbidities, okay, their diabetes, or they've got high blood pressure, mild renal impairment, or they've got hepatitis B. Okay, these are all things that will actually impact on how you're actually going to administer these systemic steroid-sparing agents. So very important to work with a physician in this area. All patients on these agents require frequent monitoring, 2 to 4 8-weekly bloods. Okay, and in the case of biologics, particularly the TNF inhibitors, you also need to be very aware of looking for diseases where the TNF inhibitor is going to make them a whole lot worse. Okay, and in Asia, it's TB. Okay, to be very, very careful that you don't put a patient who is actually positive on their quantiferon or MAN2 on a TNF inhibitor. Okay, these patients need at least prophylaxis. All right, because of the risk of reactivation of their latent TB from the TNF inhibitor, and patients have died from disseminated tuberculosis when they've been put on a TNF inhibitor without care to their TB status. So So these are the reasons why you do need to get physician input in these patients. Okay, so what I'm going to do is just quickly go through each of these agents just to give you an idea of what they are, and mainly to just give you an idea of the standard doses of these medications, so then you can work hand in hand with your rheumatologist with a patient with active disease to have an idea of whether or not there is some room to move with increasing the systemic immunosuppression. So methotrexate has been around for 60, 70 years. We know pretty much everything there is to know about methotrexate and its side effects, which makes it a really good starting medication for paediatrics in particular, because generally we know everything that's going to happen with it. Okay, 10 to 25 milligrams once a week. It is not a daily medication, okay? It's once a week. If you give it daily, you'll end up giving them chemo and your hair will fall out. Okay, it's often used with folic acid supplementation to decrease the side effects, and the number one thing to worry about is it's teratogenic, so beware in your young patients. This includes men as well, and actually decreases fertility. So you actually need to stop the methotrexate 3 months prior to them wanting to start a family, both males and females. Imurane or azathioprine. Okay, in Asians particularly, you must be aware of TPMT deficiency. TPMT is an enzyme, okay, and if you're deficient in this enzyme, your patients will end up pancytopenic. Alright, so you can actually test for whether or not your patient is TPMT deficient, and they will actually give you a readout of how deficient they are, and you can actually adjust the dose accordingly. Or you can do what I do and just choose a different agent. Okay. If you don't have access to TPMT screening, what you can do is just start them on a low dose and watch their blood counts very, very carefully. Okay. If your patient is TPMT deficient, their blood counts will drop quite quickly. Alright, mycophenolate is another antimetabolite, typically 1 to 1.5 grams twice a day. And again, just like methotrexate, this is highly teratogenic. Okay, so you do have to counsel your patients. Are you pregnant? Are you planning on being pregnant? If you're going to get pregnant, can you please let me know? We must stop the treatment before you start trying. Okay, T-cell inhibitors, basically 2 main ones, cyclosporin and tacrolimus. The main issue with these agents is that they are very nephrotoxic, particularly at higher doses. Alright, and so basically if your patient has got renal disease or a tendency to get renal disease, you have to be very careful. Basically this includes diabetics, okay, so just be careful of their renal function. And if your patients are on it for long enough at a high enough dose, they will get side effects. So again, there is no drug that is clean. Okay, alkylators, I've just put this down up more for historical reasons than anything else. Very dirty drugs, okay, very cheap, but very dirty, okay? They literally break the DNA, alright? So, again, highly teratogenic. It causes infertility, okay, in males and females, and it's high toxicity, alright? So basically, if you want to get your patients pancytopenic quickly, this is your drug, okay? I have sleepless nights with my patients on cytoxan, okay? I don't like it. And basically, neither does my rheumatologist and immunologist who have to actually hand this out. We rarely use these now, okay, but certainly back in the day, this was your last gasp medication. And I said before that all of these agents, none of them are stronger than steroids. Well, this is an exception. Cytoxan or the alkylators are incredibly strong, okay. They do work quicker than steroids, or just as quick as, but they come with a huge cost, which can be life-threatening. Okay. So which brings me to biologics, okay? This is a huge list, okay? And there are case studies on the use of biologics and uveitis for all of these agents, and I'm not going to actually go through each and every one of them today. But what I can say is biologics, as many of you know, are therapeutic proteins designed to block the activity of an immunoactive molecule. So they actually hold the promise of targeted treatment to try and actually stop that inflammatory cascade, try and stop it in its tracks before it actually causes all the other problems down the track or down the stream. Okay. However, they're not all clean, and I'm going to go through them all with you in a moment. But I'm just going to take a break and actually introduce you to one of my patients who I have used biologics for. Now, this is a 35-year-old male mechanic, and I've known him for many, many years with Behçet's disease. As you know, bilateral pan-uveitis, he also had ulcers, both genital and oral ulcers, and some inflammatory arthritis. And since his diagnosis 10, 15 years ago now, he hasn't been able to stop his oral prednisolone despite combinations of mycophenolate, methotrexate, and cyclosporine. So he started off on methotrexate and cyclosporine and failed that, then was methotrexate mycophenolate, also failed that. He's remained on high dose of prednisolone, quite unhappy, quite pushing on. Okay, and despite all this treatment, he lost his left eye. It's now classical, and he had ongoing recurrent posterior uveitis. Lo and behold, being young, okay, he was found to be a steroid responder. Okay, and this is in 2012, 4 years ago now. He had a further flare of his retinitis despite this, okay, despite being on therapeutic cyclosporine, pretty much highest dose methotrexate. This is subcutaneous as well to maximise absorption, and you can see he still has these areas of retinitis from his Behçet's disease, and that's a fairly hefty dose of oral prednisolone to be maintained on 25 milligrams. It's just too high. Fortunately, I was able to get some Humira adalimumab, okay, and since that time his uveitis has remained quiescent. He's tapered off his prednisolone, he's lost 12 kilograms, he was able to cease the cyclosporine and reduce his methotrexate to 10 milligrams a week, and he remains on this, and he is no longer clinically depressed, which is what he was when I started looking after him. Okay, my definition of clinical depression is when I see them, they make me depressed as well, and he was certainly one of those. But now, you know, he's no longer depressed, he's now making off-colour jokes every time he sees me, and I don't know which version of him I actually like better. But anyway. Okay, so biologics and uveitis, these are the ones that I am just going to touch upon now in the time that's remaining. And given that my patient had Behçet's disease, I'm just going to start with interferon, which is one of the first biologics we were using. Now, it happens to be interferons are naturally occurring cytokines. Okay? It has antiviral properties, and its mechanisms of action are multiple. Okay? We produce it in response to viral infection. Okay? And as many of you know, we use it in the treatment of hepatitis and hepatitis B and C infections. And interferon beta is what we use in MS. Okay, now, there's quite a few studies now looking at interferon alpha in uveitis, and it was first used in Behçet's disease 20 years ago because it was thought that Behçet's was actually a viral-mediated disease rather than an autoimmune disease. Okay, and these are the typical loading and treatment that's in the literature. And you can see here from Manfred Zierhard's group that very effective in the treatment of cystoid macular edema from uveitis. And certainly in Behçet's disease, particularly, it's been found to be quite effective with sustained remission. That's no relapses over a mean follow-up of over 2 years, okay, even after ceasing treatment and up to 40%. So really quite significant results with interferon, and certainly particularly in the Behçet's patients. However, as I said before, no drug is clean, okay? Flu-like symptoms in 100%, so that's rivaling prednisolone with regards to incidence of side effects. Leukopenia in a fairly high rate, so you've got to really watch those blood counts, okay? And depression and suicidal ideation, okay, in 1 in 10, quite high, okay? And certainly in my clinic, every patient on interferon needs to have a psychiatric evaluation and ongoing follow-up because of the depression these patients can get. And so basically, the frequency and severity of these side effects indicate that they're not trivial, okay? So it tends not to be first-line treatment in these patients, okay? Even in the Behçet's patients, we do try the other agents first. Okay, tumor necrosis factor inhibitors is another huge group of biologics. Okay, TNF in itself is important in the initiation and propagation of the immune response, so it seems to be a logical target. Basically, there are a lot of TNF inhibitors that are now FDA approved for a whole range of uveitis-associated diseases, and most recently in uveitis as well. Okay, whether or not it's going to also be available in Asia, I'm not quite entirely sure. Okay, these are the different TNF inhibitors. You've got chimeric ones, which are part mouse, part human, and then you've got completely humanized, which is the adalimumab and golimumab. Okay, infliximab is the first one that we actually had exposure to, and that's what my young boy was treated with. And basically it's an IV infusion, okay? But certainly a lot of case reports, this is in Behçet's disease, up to 9% response rate. So it can be very effective, particularly in Behçet's disease. And this is just a graphical representation of degree of inflammation on the inflammation scores with the biologic. Okay, now the only issue here about TNF inhibitors is that not everybody responds, okay? And tachyphylaxis, certainly now that I've been using it for a few years, is really common. And so even though, say, with the infliximab infusions, they're usually 2-monthly infusions, I'm now having patients who need to have their infusions earlier and earlier to be able to maintain that effect. Okay, anti-drug antibodies also occur with immune-mediated drug resistance as a result of causing that tachyphylaxis, but you can also get drug-induced lupus, particularly with infliximab. Okay, we've also found very high rates of toxicity with infliximab, particularly in comparison to other non-ocular indications, such as rheumatoid arthritis, and again that might be because we need to use higher doses in order to get into the eye. Okay, and as I mentioned to you before, you must check for tuberculosis before thinking about starting a TNF inhibitor, and also you need to exclude demyelinated disease. So really use in caution in patients with intermediate uveitis and vasculitis with vascular sheathing, particularly in young women, because of that risk of multiple sclerosis. So all of my patients who fall into that group get an MRI of the brain first up. Okay, Humira, fully humanised, and the advantage of that over infliximab is as a subcutaneous injection every 2 weeks. Okay, there's a question of whether or not it's got a better safety profile. There's less incidences of drug-induced lupus in comparison to infliximab. But there are also questions about whether or not adalimumab, as a result, is actually less effective than infliximab. Okay, and there certainly have been a couple of studies that have tried to actually look at that. Okay, now these are the results from the very recently released visual trial results. This was a randomised control or randomised trial of randomised control trial of patients with posterior, intermediate, and pain uveitis that was non-infectious. Patients were randomised between getting active drug, Humira, versus none. Okay, and so basically patients were slowly tapered off their prednisolone, as well as their and kept on their concurrent other medications. You can see here with rates of relapse in the follow-up period after the steroid dose was tapered off. You can see this is the group that were on the placebo, and this is the group on Humira. So 2 things from that is that basically, yes, Humira works, 30% reduction in relapse rates, but not everybody responds. So they still had a decent number of patients who still got relapses despite the TNF inhibitor on board. This is just a slide showing that unlike infliximab, the toxicity or the side effects from Humira in uveitis patients seems to be very similar to, say, rheumatoid arthritis and JIA or the other indications for using a TNF inhibitor. How about other TNF blockers? Yes, there's lots on the market. I would just like to say very quickly that etanercept, which is a different sort of TNF inhibitor, it's a receptor antagonist, is not as effective in uveitis, okay, and that parallels the literature in inflammatory bowel disease. Okay, how about intravitreal TNF inhibitors, okay? How about intravitreal infliximab or adalimumab? And basically the answer is don't go there, just don't use it. Okay, the reason for that is because it's been found to actually cause quite severe and fulminant uveitis, okay, in a subset of patients, so best not to go there. Okay, quickly, rituximab is a B-cell inhibitor, which is interesting that it actually works in diseases like rheumatoid arthritis, which we initially thought were T-cell mediated diseases. It certainly has been approved for treatment of a lot of other conditions like rheumatoid arthritis, but not yet for uveitis or Behçet's disease. I've generally used it in patients with scleritis and orbital inflammatory disease. You can see here this gentleman was on mycophenolate and 20 milligrams of prednisolone and still had quite a lot of active scleritis, and this is with him. This is 44 weeks out from his rituximab infusion, and he's still under control now, which is a nice response. Okay, so what we found with rituximab, reduced activity of scleritis and orbital inflammation, okay, correlating with good B-cell treatment. However, patients generally need to be retreated at 6 to 12 months. Okay, and this is my patient again, post-scleritis flare. You can see that his posterior scleritis has settled down quite nicely in rituximab. Okay, and I'll just skip through here. Tocilizumab is an IL-6 inhibitor. IL-6 is another common cytokine elevated in uveitis eyes. It's either IV or subcutaneous. There are a lot of reports of tocilizumab being very useful in the treatment of cystoid macular edema, and this just is taken from one of those studies. and currently under trial in a randomised controlled trial at the moment. Secukinumab basically is an IL-17 inhibitor. Essentially, I just wanted to raise it. It just shows that there are a lot of biologics that have been sort of trialled, but like this one, don't really meet their efficacy and have been found not to be effective anymore. Apremilast is interesting. It's an oral medication, and it's a PDE4 inhibitor, so quite different. It's currently under trial for checks with uveitis, and we're hoping that it might be effective. This is the last slide on biologics, essentially. This is a anti-CD28 study, and this was a phase 1 study, and CD28 seemed like a good idea at the time, might be really effective in treatment of autoimmune disease, but unfortunately in the phase 1 studies, they had 6 healthy volunteers, all of which ended up in ICU from a cytokine storm, despite using 500 times less the reported effective dose. Okay? And so it sounded like a good idea at the time, but it just shows you that with biologics there's a lot we still don't know. So just the last word on biologics. Okay, there are new therapies, and a lot more on the horizon to treat immune-mediated diseases, okay, and they are increasing exponentially. There are so many on the market. You just saw my slide before of about 12 different medications, but there are so many more. But with our experience with anti-CD28, surprises do happen, so just be careful if you're going to use it off-label, all right? And these are very expensive medications. And as a result, they are certainly not first or second line treatment in uveitis. So, just a few take-home points about treating non-infectious posterior uveitis. Always think infection. I think I sort of hammered this in a lot. Local therapies, either orbital or intravitreal triamcinolone, have limited action. Okay, they only last up to about 6 months. Okay, so they're not your long-term treatment over and over and over again, unless your patient cannot take systemic treatments at all. Okay? Never leave your patient on high-dose oral prednisolone. Okay? You'll end up shortening their lifespan because of all the side effects. Okay? And in all patients with systemic immunosuppression, co-manage them with the physician. Okay, thank you. Questions? Yes.
How's your direction for us? Sorry, I know how's your direction for us?
Oh, task, yeah.
And your follow-up. Because you still need to be vigilant and to do our best.
Yeah. Okay, so basically the question is about how do I manage tasks. So essentially they typically don't present with a lot of pain. They've got the inflammation. I monitor them. Okay, so as I said before, I keep them in the rooms or I keep them in emergency and I monitor them. And basically with tasks, it's bad and then it slowly gets better or it stabilises. Infectious endophthalmitis, though, over the course of 6 hours, they get a whole lot worse. Okay? And so then I just basically tap and inject them and treat them as though they're infectious endophthalmitis. If in doubt, or if they come in at 11 o'clock at night, okay, I'm not going to keep seeing them every 2 hours over the course of the early hours of the morning. And so in those situations, I might actually direct to tap and inject them instead. With regards to management, the task will settle down, okay? And so basically, if they came in at, say, 8 o'clock in the morning, I watched them at 4 o'clock in the afternoon, they're actually looking a little bit better, or they're looking around about the same, certainly not a whole lot worse, okay? I'll manage them topically, just with a bit of Predfort, even though they've got a stack of steroid in the eye, it'll settle down. I'll see them the next day, just to be absolutely sure, and then the more likely they're stabilised, I don't see them quite as often. Yeah. How often do I see taps? Yeah, so basically, in the past year I've had one case, and I've probably done about over 250 of them. So yeah, it's not common, but it does happen with both preservative-free and non-preservative-free. So preservative-free and preservative-containing. Okay, thank you very much. Oh, there's another question, sorry.
Before we start immunosuppression of hypersteroids, I have to say that we need to screen the TB.
Absolutely, absolutely.
In some hospitals, we don't need any quantiferon aspect.
Yeah.
So today, is it necessary to get this test? And how do you recommend if the hospital have got any assay like that?
Yeah. Okay, so one thing I did put up there is my basic sort of screening prior to starting systemic immunosuppression. It includes all bloods, so your FBE, UCs, LFTs. I look for all infections, so Hep B, Hep C, HIV, okay? And I also do TB screening. Now, in my institution we've got quantiferin gold, but a Mantoux is just as good, all right? The reason why I do TB screening in these patients is not because I think they might have TB uveitis, but because of the risk of the latency, immunosuppressing my patient, that increases the chances of them getting disseminated TB. And so I always look for it in a chest X-ray, obviously. Again, looking for those apical lesions. Now, in these situations where, say, they've got Behçet's disease, I'm fairly confident they haven't got TB. Okay, if they have been found to have latent TB exposure, then essentially they need at the very minimum 9 months of isoniazid prophylaxis at the time of starting their treatment. So it is important, and it's really extrapolated from the HIV literature, where if you immunosuppress for a long period of time, the chances of getting reactivated, disseminated tuberculosis is quite significant. So those are my routine sort of investigations that I look for. The other thing that I do with all of my patients is I also get them screened for malignancy. So for women it's a pap smear as well as a mammogram as well. Okay, and for men it's it's the same thing there, the chest X-ray and PSA. So these are all the things, again, managed with a rheumatologist or a physician, because more often than not that they might have some mild renal impairment or they might have some hepatic dysfunction. And in Australia everyone drinks, so basically it's an issue with methotrexate and mycophenolate with regards to taking that into account when we start on patients and those medications.
Another question. In terms of the Behçet disease,
yes.
Today, do you start immunosuppression at the time of steroid cases?
So basically, with Behçet's disease, we know that when it starts off, you get that crescendo over 5 years, so they're going to get a whole lot worse. And so there are some diseases where I will start systemic immunosuppression first up. Behçet's is one of them. Sympathetic is another one, and occlusive retinal vasculitis is another. Again, first dealing with or excluding infection first up. I'm just thinking serpiginous is another one that I would also start immunosuppression. Most cases of multifocal uveitis. So it's all the ones where they tend to have recurrent diseases, recurrent relapses that are imminently site-threatening. Okay? As opposed to say HLA-B27 acute anterior uveitis, you generally can just treat them with drops. It's not immediately site-threatening. Every time you get an attack, you're always going to be able to bring them back. But with Behçet's, if they get that retinal vascular occlusion, that's it. Oh yes.
I have 2 questions. The first one, in case you initiate with metronidazole bolus and you start right after the immunosuppressive, do you afraid of the side effect of like a posterior hepatitis, acute something?
Yeah, these are all the issues that yes, there's always a risk of those of the toxicities. In my practice, we have a lot of patients also with diabetes, and so typically into ketoacidosis is another issue as well. So again, I usually manage them in conjunction with a physician to help manage these things. And certainly in your population here, hepatitis B and hepatitis C are big issues with regards to systemic immunosuppression, which is why I screen for these conditions at the very get-go. At the very immediate sort of thing, you're talking site-threatening disease if you're doing IV methylpred, and so these are the things that we can actually work around with the physician with regards to starting them on, say, interferon treatment for their hepatitis. Usually the steroid is not a big issue in the initial first few days, so to give us a few days to try and get everything else together. But IV methylpred at such high doses is usually imminently site-threatening disease. That's when I would use it.
And the second question is, do you use the ICG guide for the monitoring of treatment for like a sympathetic anemia with an increase or reduce?
Yeah, so you use it, was that ICG? Yeah, so that's part of my next talk. So I use the use of other imaging techniques for monitoring. This was just trying to give you just a guideline or a framework framework. It's not specific to any particular condition, because to do that we'd be here all day just talking about posterior uveitis, which I'm happy to do, but I think most of you might get a bit bored. Okay.
Right.